afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on the Ontario Marginalization Index updates and products. My name is Laurie McKinnon. I'm the Manager of Analytics Services at Public Health Ontario, and I have the pleasure of moderating today's session. I would like to begin by saying I acknowledge and respect the land, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I acknowledge and respect the traditional territories and communities of the Métis Nation of Ontario. I acknowledge and respect Inuit connection and contribution across these lands and waters. Please join me in acknowledgement and respect for all Indigenous peoples. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual benefit of all in Ontario. Before we begin the session, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. A discussion and question period will follow the presentation. Please use the Q&A pod if you have any questions during the session or during that discussion and question period. If at any point during this session you experience technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I do manage the Public Health Ontario employees involved in the work presented today, but I have no conflicts of interest. It is now my pleasure to introduce the speakers for today's presentation, Dr. Flora Matheson, Trevor Van Engen, and Stephen Johnson. Dr. Flora Matheson is a scientist and sociologist at the MAP Centre for Urban Health Solutions at St. Michael's Hospital, Unity Health Toronto, who explores gender-based inequities in health among people experiencing complex health and social needs along two priority areas: problem gambling, poverty and homelessness, and traumatic brain injury and criminal justice involvement. Trevor Van Engen is an epidemiologist lead in the informatics department at Public Health Ontario, whose work focuses on advancing the reporting systems for population health inequities, including the development of updates to the Ontario Marginalization Index. And Stephen Johnson is a senior geospatial analyst on the analytics services team at Public Health Ontario. He works closely with PHO program areas and external stakeholders in the areas of spatial data creation and management, supporting infrastructure, spatial analysis, and dissemination of spatial products using both desktop and cloud-based dynamic visualization technologies. And with that, I will pass it over to our first speaker, who is Dr. Flora Matheson.
Thank you very much, Laurie. This is just our disclaimer, and I'll just pass over that. This is just an overview of what we're going to be talking about today. So our presentation today will provide a background on the Ontario Marginalization Index. That will be followed by a demonstration of the Ontario ON-Marg Index map and some limitations and considerations when using ON-Marg. For those of you who are not familiar with ON-Marg, it's an index that provides an opportunity to explore differences across geographies. It can be used to understand health and social behavioral inequities, either between population groups or between geographical areas. I want to talk to you a little bit about how we developed ON-Marg. To do this, I need to talk a little bit to you about how we derived the Canadian Marginalization Index, because ON-Marg sprung from the Canadian Marginalization Index. So CanMarg, its development started back in 2002 during my postdoctoral studies. At that time, we wanted to develop a Canadian index of marginalization. So we began by looking at what had already been done historically on area level social structural indices of deprivation and inequality. This provided the theoretical framework for us to work from. So we identified approximately 60 historical indices, and then we identified the variables associated with those indices. We then took these predefined variables and went to the Canadian census data and looked to see if we could identify the same variables in the census data. We weren't able to find all of them, but we did find 42 variables to work with from the census data. We used a procedure called factor analysis, which provides a way to reduce a large number of variables into a few factors or dimensions. This procedure identified 4 dimensions, as you see here, with a total of 18 variables. Each dimension has a different number of variables associated with it. These dimensions have been quite similar or consistent in nature across the census years for the Ontario Marginalization Index. A little bit more about the ON-Marg dimensions. They're linear combinations of the 18 input variables that independently explain the greatest possible variance in the data. Each dimension is designed to be used as a separate index that is standardized, and each can be used as standardized scores or as quintiles. You may have noticed this year that the names of the dimensions for the 2021 version of the ON-Marg have changed. There have always been concerns raised that the original names of the dimensions, that they may have been stigmatizing some populations and that they may contain outdated terminologies for describing racialized populations. Both Public Health Ontario and the team at Unity Health Toronto were interested in moving from the use of deficit-based language to the use of strength-based language, and to address concerns we were hearing from the people who were using ON-Marg. So we reached out to our partners and asked them for their thoughts on how to rename the dimensions. So let me introduce each of the dimensions with their names based on these consultations. Just a reminder again that the variable names haven't changed within each dimension, just the names of the dimensions themselves. So here you see households and dwellings, which was previously called residential instability. This dimension relates to family and neighborhood stability and cohesiveness. Indicators include types of and density of residential accommodations and characteristics of family structure. So when we think about the context of area level households and dwellings, we can think about the ways in which neighborhoods can be cohesive and supportive, or not cohesive and not supportive, and can contribute to good health or poor health, and the ways in which they may promote poor health and good health through structural and systemic factors. The next dimension is material resources, which was previously material deprivation. This dimension is closely connected to socioeconomic status. For example, the inability or the ability for individuals and communities to access and attain basic material needs related to housing, food, clothing, and education. If we think about the context of area level material resources, we might think about the pervasive impact that socioeconomic position has on a person's well-being for a variety of reasons, such as educational attainment, housing and financial security or precarity, and food security or insecurity. The next dimension, which was previously dependency, is now named age and labor force. This dimension relates to disability and dependence and refers to area level concentrations of people who don't have income from employment, for example. This would include older adults, children, adults whose work is not compensated, and or those who might be unable to work due to disability. So we think about context in this for age and labor force dimension. At the area level, we might think about the economic vitality of communities and how resources are allocated to ensure, for example, that people with disabilities and or seniors or elderly people have access to appropriate resources that enable their well-being or don't enable their well-being. We can think about what structural and systemic factors create barriers to well-being based on area level age and labor force inequities. And then the fourth dimension is used to be called ethnic concentration and is now called racialized and newcomer populations. It reflects newcomers and or non-white, non-Indigenous populations, and relates to impacts of racialization and xenophobia. The change in title of this dimension is important given the history of structural and systemic racism in Canada. We know that racialized groups experience differential treatment on the basis of race, ethnicity, language, religion, and/or culture. We also know that there's a healthy immigrant effect, but that research is very clear that both structural racism and anti-immigrant discrimination have profound effects on individual, community, and population health. So being mindful, deliberate, and clear about the context of historical, structural, and systemic racism when we use any of the dimensions of ON-Marg, but especially when you use the racialized and newcomer populations dimension, is and will continue to be important in our work and how we use these dimensions. The final thing I want to talk to you about is on the ON-Marg geographies themselves. We do encourage people to use ON-Marg at the dissemination area level if possible. This reflects the smallest standard geographic area at which census data are disseminated. ON-Marg is also available at other geographies, including census tracts, aggregate dissemination areas, public health units, census divisions, and census subdivisions. ON-Marg scores can be derived from custom geographies. For example, the Ontario Community Health Profiles Partnership at Unity Health Toronto creates the scores and the quintiles at the Toronto neighborhood level, and these are available on their website. So I'm going to pass it over to Steve now to proceed with the presentation of the ON-Marg index map.
Thank you very much, Flora. So now I'll provide a quick demonstration of the new map resource available from the Public Health Ontario Marginalization Index webpage. And this map launched just yesterday. If we look at the ON-Marg Index webpage, there is a link to the new map. And if we click on that new link, it will launch the new Ontario Marginalization Index map. And this map replaces the previous social determinants of health map on the PHO website. And it uses a faster, more user-friendly visualization format while also adding the new 2021 ON-Marg data by dissemination area geographies. On initial load, the map shows the entire province of Ontario. The left side of the map contains a sidebar with links to the user guide, a link back to the PHO ON-Marg page, and a link to the data sources documentation. The sidebar also contains additional information about the ON-Marg indices, as well as a legend to determine what you're looking at in the map. And in this case, it is the material resources layer by dissemination area, along with the public health unit geographies. In the top right of the map, there is a health unit dropdown showing the operational names of the health units, of the public health units in Ontario. And you can choose to select a health unit either through scrolling through the list, or if you happen to know which health unit you're interested in, you can do a quick short list by typing in the text in that box. So once a health unit is selected, the zoom changes to the extent of the chosen health unit geography, and the charts along the right of the page populate with data for each of the 4 ON-Marg indicators. So it is showing the number of dissemination areas, geographies within each of the 5 quintiles for the selected health unit geography. There are also 4 tabs along the bottom of the map. One for 2021, 2016, 2011, and 2006. So one for each of the previous ON-Marg years. And these tabs allow for easy comparison of the geographies over time, as well as the charts along the right as they also update for each tab. Within the map itself, you have the ability to zoom and pan around like any interactive map. And when you do so, it will, again, change in each of the different tabs, again, for easier comparison over time. You also have the ability to turn within each map to turn the layers, the administrative layers within the map. So the health unit boundaries, the Ontario Health Region boundaries, and the LIN boundaries, you have the ability to turn those on and off, as well as the 4 on-Marg dimensions. So the material resources is shown by default. You can turn that off and turn on the racialized and newcomer populations, age and labor force, and households and dwellings. You can also search for areas of interest using the search bar. And it will take you to that area. And you can also change the base maps used within the map for reference. There is also a hamburger menu dropdown in the top right. And this can be used as another way to access the user guide, the ON-Marg PHO page, and the data sources that are contained within the map. And with that, that is about it for the demonstration of the new map. Have fun with it and explore. And we hope that users will benefit from using this new resource. And I just want to say a gentle reminder just to explore the user guide to best use the new map. And now I will pass it over to you, Trevor, to continue the presentation.
All right, thanks very much, Steve. So I'll be speaking next about how ON-Marg can be applied in public health, including some examples of how it's been used. I'm also going to address some considerations for respectful and appropriate use of the index for describing inequities amongst marginalized populations in Ontario. So in public health, a common need for ON-Marg is to link health data with socio-demographic characteristics to better understand and address the health inequities in Ontario. So as an example, we typically have health data which contains robust geographic information, allowing us to map out patterns of health status, but the demographic information is often limited to age and sex. So on this slide, we're showing a map which contains the rate of 2 or more chronic conditions across Toronto neighborhoods, where the darker shades indicate worse health status. So you might notice that the patterns on this map reflect similar patterns to what Steve was showing in the Ontario Marginalization Index map demonstration, where you have pockets of better health status and less marginalization in the middle of Toronto, with pockets of poor health, more marginalization to the east and to the west. So noticing these similarities doesn't really quantify or capture how well the two are related. So ON-Marg can help fill this gap by allowing us to assign cases or patients to a level of socioeconomic marginalization based on the dissemination area that that person lives. So in most examples, cases are assigned to DAs using the postal code conversion file, or the PCCF+, which then allows us to assign the ON-Marg quintile or score based on the particular DA a person lives in. We can then aggregate this information into quintiles, where we often see this gradient pattern where the lower marginalization quintiles have better health, or less poor health status. And as you get more and more marginalized, the health decreases, or you have more poor health. And we often see this as a stepwise gradient across all quintiles. We can then quantify and summarize this relationship using summary measures of inequality. So the rate difference and rate ratio compare the highest and the lowest quintiles, while more complex measures like the slope index of inequality or the relative index of inequality capture this relationship across the spectrum of quintiles. This then allows us to report on statements like premature mortality rates are 3.6 times higher in the most marginalized quintiles compared to the least marginalized quintiles. So more specifically, we've identified 4 potential use areas for ON-Marg. We have planning and needs assessment. Second is monitoring inequities. Third is resource allocation. And fourth is for research. As an example of the first use for planning and needs assessment, I'd like to showcase an example from PHO's COVID-19 response. In the early days of the pandemic, there was a lack of socioeconomic data in Ontario about people with COVID. And so ON-Marg was used to measure the burden of COVID, in this example, across quintiles of marginalization. So in this, we're using the, at the time, we were describing it as neighborhood diversity, but it's the racialized and newcomer population. And so for these 2 weeks in October of 2020, ON-Marg was used to show that the burden of COVID-19 incidents was 7 to 8 times higher in the most diverse quintiles, so the most racialized and newcomer populations, compared to the least diverse quintiles. And having this information was helpful in influencing the vaccination planning. So of course, a lot went into the vaccine rollout, but with varying degrees, provincially and across the different health units, this data was a factor taken into account to target vaccinations. We can also use it to monitor the program rollout. So in the figure on the right, we're showing rates of 4 different vaccination status. So we have the leftmost bars are showing at least 1 dose. Then we have series completion or 2 doses, series completion with 1 booster, and series completion with 2 boosters. And these are broken down by quintile of neighbor diversity or racialized and newcomer populations. And so what we can see that for first and second dose, the program did a very good job of targeting this, high disease burden group, this high needs, these quintiles. But as the rollout went on, it was less effective at reaching the most diverse quintiles for the booster doses. As COVID went on, we began to use it for monitoring inequities in COVID-19. So this figure shows rates of COVID incidents across quintiles of material deprivation or material resources. There is a fairly consistent pattern where the most marginalized, the neighborhoods experiencing the highest rates, highest amounts of material resource related marginalization experience the highest rates of COVID-19 per 100,000. But there were definite periods where this relationship changed, and highlighted here, this is the period just following that initial Omicron surge where we actually see that relationship has changed. And so having this information to be able to see how things have changed over time is very helpful to plan responses and understand what's driving these inequities. ON-Marg is sometimes used for decisions around resource allocation. So in this example from the Toronto Catholic District School Board, they use ON-Marg to understand sociodemographics of the school communities and the neighborhoods in which students live, and to use that information to resource schools in an equitable way. So they mention using the material deprivation index to target additional funding to the schools that need it most because of the populations in which their students live. We also see a lot of uptake of ON-Marg in peer-reviewed research, especially in use in statistical modeling. So this is an example from a recent publication that looks at loneliness amongst older adults and comparing immigrants to Canada versus Canadian-born individuals. And so this publication used the factor scores in their models to measure the impacts of the neighborhood on health status. So they use this is the racialized and newcomer dimension to show that immigrants who live in very diverse neighborhoods had more protection against loneliness compared to Canadian-borns or compared to immigrants living in not as diverse neighborhoods. So now that I've discussed some of the examples of use, I'm going to describe some considerations for more appropriate use of the index. So ON-Marg is not without its limitations. The first is that it does not address all forms of marginalization. So for example, Black populations, Indigenous populations, women, and LGBTQ plus populations may experience marginalization in ways that are not captured by ON-Marg. So specifically, while Black populations are included in the racialized and visible minority indicators that go into the racialized and newcomer population measure, by combining all racialized groups together, this has been described as diluting and obscuring the experience of distinct racialized groups, and in this case, in particular, the impacts of anti-Black racism. Further, while Indigenous people are included in the census and captured in various ways, there is no indicator for Indigenous status, and there was no variable for indigeneity that loaded when the original index was created. So it's our recommendation to supplement analyses with other approaches to better understand the impacts of specific, driving factors causing health inequities. In this case, anti-Black racism, colonialism, or others that may apply depending on your analyses. The second is that the index uses Canadian census data, which is only refreshed every 5 years. And also, not everyone is counted within the census. So there is data suppression for some indicators on Indigenous reserves, which means that there are no on-marg scores or quintiles for DAs in the province that are on Indigenous reserves. Further research has shown that there is an undercounting of Indigenous populations who live off reserve. And finally, temporary foreign agriculture workers and people living in congregate settings do not contribute to some of the census questions, and therefore are not, it's important not to generalize findings using on-marg to these populations. And lastly, I want to talk about ecological fallacy. So some people within a neighborhood are not going to be represented by the neighborhood average. And there's a risk of misclassifying individuals if on-marg is used as a proxy for individual socioeconomic status. So as Flora mentioned, it's best practice to use the smallest level of geography available, which is in this case the DEA, as a way to minimize that misclassification risk. Another way to think of this is if you were to look at a PHO level, Peel Public Health is the most diverse health unit, but it would be a mistake to assume that everyone living in Peel is themselves racialized or a newcomer. And it's also important to recognize that health equity analyses, by describing and shedding light on the health status of specific communities, it may run the risk of causing unintended harms by stigmatizing communities, furthering of negative stereotypes about the people who live there. At the same time, understanding and measuring health inequities is an important step in being able to address them in the first place. So we want to make sure that as much as possible, we're trying to reduce and mitigate the risk of stigmatization. One way to do this is that, to ensure that analyses are grounded in a critical and respective approach, it's important to clearly articulate the purpose and the use of health equity data, especially in how the data can benefit impacted communities. And next, it's good to recognize that the inequities in health status that are observed using on-marg, that these are driven by underlying social and structural factors. It's really important to highlight the role of the contextual factors, especially ongoing and historical structures, policies, and practices in driving inequities. So a great example of this is when using the racialized and newcomer population, providing that context about the impacts of racism and discrimination on health can help make the findings more relevant and more respectful, so that there's the risk of stigmatizing these populations by allowing readers to make untrue conclusions is limited as much as possible. When developing this new release of on-marg, we've updated the user guide documentation so that our dimension descriptions contain more of this expanded contextual information about how the dimensions relate to these underlying structural and social factors, so that users have more resources to enable to better further this approach of providing that important context in our analyses. And we hope that having this information available is able to promote respectful use of health equity analyses and the index in addressing health inequities. And finally, it's important to incorporate the perspectives of impacted communities. This can provide very helpful context and also strengthens the relevance of findings. Now, it's not always feasible or possible to conduct direct engagement, but this doesn't mean that it's something that shouldn't be done. You can incorporate the perspectives of impacted communities by looking at the literature, existing frameworks, and the knowledge informed by perspective of impacted communities. So the index itself, as well as our user guide and frequently asked question documents, can be found on the Ontario Health Profiles Partnership website, as well as the Public Health Ontario website of the following links. And finally, if you have any questions about this presentation, or especially about the Ontario Marginalization Index, Flora and I are happy to answer any question at all. And our email addresses are provided here. So that's all I have for my presentation. I'm going to hand it over to Lori now for the Q&A segment.
Thanks, Trevor. So thank you to Flora, Stephen, and Trevor. We're now going to move into the Q&A segment of this event to address some of the questions from our audience. A quick note to everyone, please continue to enter your questions into the Q&A pod if you had not already had an opportunity to do so. So the first question that we have, has it been shared how much variability is explained within each dimension?
Flora, please feel free to jump in as well. We have provided in some previous resources, I believe it's the eigenvalues are some of the technical characteristics of the dimensions, which can be used to describe that characteristic. I don't know them offhand. I do know that it's varying across each dimension, and maybe Flora has some better context.
No, I think if it's not in the technical guide, then we do have it. It just, I'm not sure if we published it all at this point in time, Trevor. But we do have that information because we would have looked at it ourselves, right?
There is a follow-on question. So the person is specifically looking at the variance explained within the PCA. I don't know if you have anything else.
Yeah, unfortunately, that's not some information I have on hand. Maybe I can multitask and look at some of our literature while we answer these other questions. And I can provide the information in the chat, maybe.
Yeah, or it could be a follow-up question, like we could provide that later. Yeah.
It is, I know, sorry, we have published 2 publications. The original CanMarg paper has that information in it, and I believe it is in a subsequent paper that Flora and I published a year or two ago, looking at the development of the 2011 and 2016 indices.
Right, so not specifically on the 2021, but on the 2011, yeah.
It is fairly consistent, I would say, across years.
I would agree.
Those links, by the way, are on the Public Health Ontario website for those papers.
Great, thank you both. Our next question, has anyone checked the original factors against the current environment in Ontario, or any thoughts on whether it may be important to check if the factors still hold true?
I'm not quite clear on the question myself. The current environment.
Do you mind if I take a stab? I think this question relates to the fact that the original, when the index is updated, we are keeping the same 18 indicators that loaded in the original the first iteration of the index.
Right.
And we have, this is a deliberate choice to try and maintain the stability of the indicators that go into each factors in order to improve the ability to interpret changes over time. And the big concern is that if the index is allowed to vary year over year, it might make interpreting changes in outcomes, as the indicators move in and out of dimensions and indicators shift around, it might make that very difficult, because it'd be very hard to say whether or not changes in inequities that you're seeing are related to changes in the index or changes in the distribution of health inequities in the province. So
And
this
Trevor,
was, yeah, go ahead.
sorry, Trevor, there's a follow-up question. So was there any concern about the temporary decrease in income inequity in 2020 and 21 due to the government transfers during the pandemic?
So yes, we were very interested in the census was collected in the midst of the pandemic, in a huge change in EI and government support programs. So we did look to see how the variables reacted differently. In particular, of interest was the variables around low income. Previously, the index included or used the low income cutoffs, or LICO, and when we initially built the index using this variable, we found that it did not perform as well. It was a very weak loading, and it also wasn't definitively loading with the material resources dimension. We think this is related to the way that between 2016 and 2021, the amount of low income that was measured using the LICO was about halved in 2021. Possibly related to this transfer. That's probably the biggest thing driving these changes. And we saw that the impact on another commonly used measure, the low income measure, was not as severe. And when the low income measure was used, it provided a much more stable iteration. So, and Flora, please feel free to comment. I don't feel personally like we understand all the ins and outs of the complex interactions of government programs and low income and what was happening in the pandemic, but we switched to using the low income measure because it provided a more consistent and stronger conceptual measure that the low income maybe not being as sensitive to the impacts of low income provided during the 2021 census.
Agreed.
Anything that you wanted to add, Flora?
No, agreed with that. Definitely. Thanks.
Okay, thank you. So we have a couple of questions about the map. So over to Stephen. The first question, which I typed in answer to, but we'll ask it so everyone knows, was which software was used to develop the map?
So it was the Esri suite of softwares, and it was all within ArcGIS Online. And specifically, the visualization is using ArcGIS dashboards.
Okay, and another question about the map for Stephen. I can see you can map each individual dimension. Is there a way to map the 4 combined dimensions together?
Not really. The data that were created were specifically for each dimension and not as an index for all of them. But if Flora or Trevor wish to follow up with that regarding the methodology or complexities, feel free to jump in there.
Anything from Flora or Trevor?
I can jump in for it.
Sure, go ahead.
In the documentation, there is some instructions on how the dimensions can be combined, and this may be of use depending on your analyses. I feel one of the strengths of ON-Marg is being able to look at these separate dimensions of marginalization separately. I find that it's being able to look at racialization separately from the impacts of poverty allows you to be much more specific in the analyses and interpretations, and combining them, while it might have some specific goals, it makes it difficult to really understand what are the drivers of the inequities that are seen. So there are other tools and other indices and other ways to look at combined approaches. I think ON-Marg having 4 separate dimensions provides a lot of granularity, a lot of flexibility, and a way to get at a more nuanced picture of marginalization. So for that reason, we it's possible, and we provided the instructions on how to do so, but it's not been included in the map tool as a way to keep emphasizing that ability to look at the dimensions separately.
And I would just add, one of the concerns about aggregating the dimensions is that the effect of one versus the other may operate differently with whatever outcome you're looking at. So if you're looking at racialized and newcomer populations versus material resources, and you're looking at a health outcome, and I'm thinking about a statistical model, the impact on the health outcome for racialized and newcomer populations may be, there may be a negative effect, but with material resources, it may be a positive effect. So what you're doing is you're diluting the effect if you're aggregating those two together. So if you're going to aggregate, you should actually look at the dimensions separately first to see how they're interacting with, or what the association is with whatever outcome you're looking at before you make the decision to aggregate. So you actually know what that association is before stepping into that kind of that zone of aggregation, so to speak.
Great. Another question, maybe we'll start with Flora first and then move to Trevor if he has additional comments. Could you comment on the utility of ON-Marg for pediatric population, and for example, examining disparities in health outcomes?
I know that people have been using ON-Marg for pediatric, to study pediatric care. I know folks at ISIS have been looking at pediatric care. I don't know the specifics of it, but if you're looking at inequalities or inequities at the neighborhood level and their impacts on pediatric health, I think it makes sense to look at particular aspects of marginalization. So I think from my perspective, that is an option, and I can see how it would be something that would be of value. I'm not quite sure in terms of what you're looking for in terms of comments on this, but I would say that it is something that you could explore.
Anything to add, Trevor?
Yeah, I mean, the classic epidemiology answer is that it depends. So I do think that it depends on specifically what aspect of pediatric health, but we at PHO, we've used it to look at low birth weight. Elsewhere, it's been used to look at child health. And I do actually feel like it is a strong, it's a very good use of these indicators of this dimension, because there is no lag between where a person lives. There's no life course history that has to develop outside of that immediate interaction between where a person currently lives and where that pediatric outcome happens. So in comparison to something like lung cancer or COPD, where there's a whole life course of exposure to things like smoking or pollution or whatever else that might be obscured by the fact that this person has lived in some, born in one place, moved around, and they're now living in a different place. It's the life course of exposure to that social and economic environment that has related to this, that has caused and driven this finding. Whereas there isn't that same link, there's not that same lag when looking at outcomes in youth and children and pediatrics. So I think it is a good, where there's a much more immediate relationship between exposure to a neighborhood environment and outcome, it makes a strong case for use.
Great, thank you. And another question, is it possible to do projections and modeling regarding the index parameters? Let's start with Trevor this time.
I mean, modeling, yeah, modeling is ON-Marg has been used in all sorts of modeling. I don't know the specifics, but I have a sense it would be an interesting variable to include in any kind of forecasting around, COVID or some other disease. I assume that's what the question is about forecasting disease outcomes. We haven't used it to forecast marginalization or to extrapolate what communities will look like in the future. I don't know, Flora, do you have any ideas about that?
Yeah, I mean, we've used it for modeling, like we've used the Canadian Marginalization Index in a series of papers for modeling health outcomes like depression, body mass index. And we use it as factor scores. So you don't necessarily have to use it as quintiles. You can use the factor scores to model outcomes. And we use it in multi-level models. So we wanted to understand gender differences in health outcomes. And we wanted to look at it by neighborhood level of neighborhood marginalization. So we actually looked at interactions between gender and neighborhood level to see what the differences were in health outcomes for men and women. And so, for example, if we looked at body mass index, men living in affluent neighborhoods had a higher body mass index than women living in affluent neighborhoods. So there's lots of things you can do with On-Marg in terms of modeling, statistical modeling, and lots of things that you can explore as an individual, like as a main effect or as an interaction effect. So there's lots of things to explore and of interest. Not just in terms of health outcomes, but also, social behavioral outcomes as well. We talk a lot about health outcomes, but there are other things that we can explore with it as well.
And we have a few questions about the factor analysis. Is the methodology available? What software did you use? And is the code available somewhere?
Okay, let's work back. The code is available. We can share that. We've shared it many times. We use SAS. And then the methodology, there's lots of stuff out there about the methodology. We can send you some resources. SAGE has lots of really good resources on factor analysis. I don't know, Trevor, what you've used, but SAGE has been some of my pivotal go-tos for factor analysis. But if you're interested in that, we can definitely send you some references.
I think, yeah, the answer is please get in touch. We're happy, to engage with anyone who wants to learn more about it, and including sharing code and working through various aspects of it.
Yeah.
Okay, great. Let's see. So in the past, PHO had suggested that local analysis would benefit from calculating local quintiles from the scores provided. Would you recommend that local On-Marg scores be used when looking internally within a health unit? And also, did PHO ever provide local PHU scores in a file? So let's start with Trevor.
So yes, just to provide some context. So the quintiles represent, there's about 20,000 Ontario DAs. So the quintiles are created by grouping these 20,000 into 5 groups, where each group contains an equal number of the quintiles. So what happens is, because the characteristics are unevenly distributed across the province, you have situations like in Peel, for example, where there are very few low racialized and newcomer populations, quintiles. And so analysts might be interested in, not thinking about how the distribution of the population fits within an Ontario context, but they want to know more about the distribution of the population specifically within a Peel context. So it's not about looking at what are the 20%, most racialized neighborhoods based on Ontario, but I want to look at, the 20% most racialized DAs within Peel, or the least, or however. And this can be the case where there's a pretty, uneven distribution. I encourage you to look at the map to provide, it does a very good job of explaining and showing how marginalization is distributed within each public health unit. So I think it's something to explore depending on your question, depending on the audience. You might, it might be more meaningful to look at just specifically with the distribution of a health unit rather than comparing it to Ontario as a whole. At the same time, a Northern Health Unit where there's very few racialized people and newcomer population, maybe it's not as meaningful because you're creating an abstraction that doesn't really, hold a lot of relevance. So I think it depends specifically on the context. In some of our products, we have provided the index both ways because we have had requests for it to be looked at local quintiles and Ontario quintiles. It's not something that we have shared. I think we would be able to. It is a fairly straightforward process to do in statistical software, and I'm happy to coach someone through if we can't share it for whatever reason. But maybe Laura and I and Laura can talk about improvements we can make in that regard. But otherwise, please get in touch. Happy to help.
Anything to add, Flora?
No, because I'm not really involved with the PHO pieces.
Okay, no problem. So there was a question about the map for the link for the map. I think the person had missed it in the chat pod. So if we can ask capacity building to post it in the chat again, that would be great. And where can people find information on the 48 variables in the census that you use to perform the factor analysis?
I can probably dig those up.
Okay, great.
They are also,
go ahead.
Sorry, Flora, they're listed in the appendix of the On-Marg user guide.
That's right. Yep. Thank you, Trevor, for reminding me.
Great. Next question is for Trevor. Are you able to provide any sense of when the snapshot indicators of inequalities using On-Marg might be updated? They found those indicators very helpful as it was complicated to calculate locally.
Yeah, great. I'm happy to hear that they were of use. We are working on updating them now. I think the push was to get the index out and developed as well as SNAP program. So we are working to update them using the more, I think some of the indicators are at least 5 years out of date. So looking at the more up-to-date health status is a current priority. As you've seen, PHO, we have new capacity around dashboard development as well. And so we're also thinking of different ways in which we can integrate On-Marg into our dashboard products as well. So I don't have a specific time frame to give you, but please keep an eye out, and it is coming soon.
Great. And over to Flora for this one. Are you aware if other provinces do something similar to the On-Marg?
Yes. So it's not, I'm not sure if there's other provinces. I did have a colleague in Nova Scotia that was pursuing this. I'm not sure the status of that, but the Statistics Canada has kind of taken over or created their own Canadian index of multiple deprivation, modeling, but building on the Canadian Marginalization Index, which is no longer being produced. And they are doing indexes for provinces that are large enough and have enough data to do specific indexes, province level indexes. For provinces where there isn't a sufficient level of data or enough data on a data count, they are doing regional indexes. So they are now producing the 2021 indexes for the provinces and regions. So I'm assuming that should be out soon. I reviewed some of the work, some of their work, and so I'm assuming it should be out soon. They did the 2011, so the 2021 should be out soon. So that's the most that I know at this point in time. But if you search for the Canadian Multiple Index of Deprivation, you should be able to find some information on that. Trevor, do you know anything else? Sorry, Laura.
Not a provincially scope, but they must exist. This techniques are able to use in many different ways. So it wouldn't surprise me if other provinces do.
Right, and I believe Quebec has one as well. The Pampelon Index.
Yes. I don't believe that's been updated yet, but I'm thinking more like On-Marg is a bit unique in that it's Ontario specific, where some of these are national in scope.
Yeah, that's right.
Okay, thanks everyone. So there's still some questions in the pod, but unfortunately we have to wrap up. So I would encourage people to reach out to Flora or Trevor to ask those questions that didn't get answered during our discussion today. And as we wrap up today's PHO rounds, I'd like to thank Dr. Flora Matheson, Trevor Van Ingen, and Stephen Johnson for presenting. I would also like to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming going forward. And lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you, everyone, and have a wonderful day.